So, yes, Deirdre Schoen, Chief 2 Pharmacist based in SUH. So my talk today is on a project that I'm involved in the area of falls risk increasing drugs. Now, this project is part of an overarching project, which is in falls prevention in CDLMS. So before I get into our project, I'd like to talk to you a little bit about that overarching project. It's a 2-year project headed up by Jerry Clerkin. Our chair is Edel Brennan. She's our falls coordinator for the area, and our project coordinator is Colin. So as I say, 2-year project, it's quality, safety and service improvement initiative, and we're coming towards the end of year 1 with it. The aim of that project is very simple, really. It's to reduce the number of falls causing harm to the population of the 5 counties. And the objectives of it are to develop an overall framework, to provide guidelines for healthcare and other professionals working with older adults, to identify and assess the risk of falls, to outline the interventions that may be offered as part of a person-centred approach. And finally, underpinning all of those is the Sláinte Care ethos of right care, right place and right time. So I think it's fair to say that our falls prevention project is very closely aligned with the World Falls Guidelines that were released in September 2022. Like that, we have our working groups. We have 5 at the moment, with the potential of a 6th. The one that I'm involved in is pharmacy, but we also have residential care facilities and continence, bone health and strength, balance and exercise, structural and environmental and equipment and technology. And then supporting us all is the very fundamental group of education and awareness. And this project draws very strongly on the expertise, on the knowledge and on the experience of several different disciplines working across all sectors. We're drawn on the acute, community care, residential care and primary care. So we were very, very pleased to be asked to form a working group in the area of medication, because it meant that medication as a modifiable risk factor for falls was recognised locally, which is fantastic. And it's very close really to what the World Falls Guidelines do themselves. They also had a working group in the area of pharmacy, and it was called Polypharmacy, FRIDS and Falls. And they came up with 4 recommendations. 2 of those were assessments and 2 of them were interventions in this area. So they recommended assessing for fall history and risk of falls before prescribing any potential fall risk increasing drug in an older adult. They also recommended the use of a validated, structured screening and assessment tool to identify these drugs when performing either a general medication review or indeed any medication review targeted at falls prevention. They recommended that a medication review and appropriate deprescribing of FRIDS should be part of a multi-domain falls prevention intervention. And finally, they recommended that in long-term care residents, the falls prevention strategy should always include the rational deprescribing of FRIDS. So why the focus on these drugs? Well, we know that between 65 and 93% of older adults with a fall-related injury use at least one of them, so they are significant. We do know as well that medication review and appropriate deprescribing is one of the most effective components of the multifactorial fall preventive intervention. However, in clinical practice, managing polypharmacy and deprescribing FRIDS after a fall in adults is often highly challenging and less frequently performed than expected. So we know what the drugs do, we know what we should be doing to address it, but we're not delivering. And why is that? Well, the reason we have difficulty with it is deprescribing is a very complex process. Definition of it is a supervised withdrawal of inappropriate medications for which the potential harms outweigh the benefits. But there are several challenges to it, extremely complex. These are a few of the ones, but we could add many more to it. First of all, patient reluctance and family reluctance. I think we'd all be familiar with the patient that doesn't want the amitriptyline at night to be stopped, for example, or the family member that doesn't want the diazepam to be removed from the list. So that is an issue. A huge issue is time. It's a very time-consuming process. It needs buy-in from the patient. It needs buy-in from the family as well too, and the identification of the medication needs to happen. The process needs to be mapped out as well too. Withdrawal safely of these medications can run into months, and that needs to be planned. And finally, it's not finished at the deprescribing. There's monitoring that needs to be put in place afterwards to ensure that everything happened safely and that there are no issues subsequently. It takes a lot of time. It can be challenging to recognise the problematic medications. I think everybody would be familiar with the common ones. I think everybody would know that a benzodiazepine can cause an issue, for example, but others may not be so obvious. That's a problem. Shared care. The person that is attempting to deprescribe medications is often these days not the person that started the medication in the first place, and may not be the person that would be doing the monitoring necessarily. So we're definitely evolving more into kind of a shared care with lots of specialists feeding into the medications. So that is adding to the complexity. There is a lack of accessible guidance, and the emphasis will be on accessible guidance on safe withdrawal and monitoring. There is guidance out there, there's any amount of it. It's in different jurisdictions, it can be contradicting, and it can be difficult just to get to what you need to know. And finally, inertia. It can be tricky to decide to attempt this if your patient or your resident is safe, well, hasn't had a fall, and is managing just well on the medications that they're on. So there's lots of reasons why this isn't happening, and it's not just in this country, it's an international issue. So I suppose we were asked to pull together a group to look at these medications, and we had a couple of difficulties that we had to deal with before we decided what we're going to do. First of all, I suppose we all have full-time jobs. Everybody that's in our group is working with patients. So this is something that we were doing alongside of our normal work. So that was a thing. And also, I suppose, from the pharmacist point of view, we're not really as well distributed in terms of people interacting with people who've had falls or who are managing falls as maybe the other disciplines would be. There are absolutely a few that are involved in medication review, but if we compare ourselves to other disciplines such as the physiotherapists, the OTs and the nurses, we're nowhere near those kind of numbers. So that was difficult as well too, because we wanted to do something that was meaningful and would have an impact on the aim of reducing the falls. So how to go about it. So what we decided to do, and it was very ambitious looking at it now, but what we decided to do was to produce a falls risk increasing drug guidance document. We wanted a local one, we wanted an Irish one, to assist prescribers, to assist pharmacists, and that's all pharmacists doing medication review, through sympathy to community pharmacists with resources, and ourselves in the acute session as well too. Nurses that are looking after medication very, very closely, and also very involved now in prescribing and deprescribing, but also other relevant healthcare practitioners, everybody that manages medication for patients who are at risk of or have had a fall. And we wanted this guidance to be comprehensive, but concise. We wanted it to be easy to access, but above all, we wanted it to be useful. So just a little bit about the working group that we have. We're really, really fortunate in the makeup of our group. We have 3 superb ANPs with a wealth of experience between them in dealing with frailty, with dementia patients, with orthogeriatrics, fantastic. And apart from myself, we have 3 great pharmacists that have equally have experience working with older people on wards across the area. And we also have Lorraine Feeney, who's great. She's a GP and registrar, but she also has experience with ictop and older persons as well too. So I suppose a little Sligo-centric, I'll admit to that, but I think that's probably a reflection of the success we've had in previously working together very closely in different projects, and we know that it works. So how do we go about it? Well, I suppose we would have done medication reviews in the past, and the guidance that we would have used up until about 2020 was based very much on straightforward classification of FRIDs into high, medium or low risk. They were stratified according to that with the reasons why they were in those categories. This was not standardized at all. Very different ways of doing it across Europe. And we locally were using NHS resources because I suppose the list of medications available in the NHS is probably the closest to what we would have here. But it wasn't ideal either. We have medications in this country that aren't available in England and vice versa. So we were adapting, we were making do, but it wasn't ideal. So then in 2019, 2020, Stop Fall came, and you'd probably be very familiar, most of you, with Stop Fall. It's a screening tool of older persons' prescriptions in older adults with high falls risk. And what they aimed to do was to harmonise all of that practice and the guidelines on drug-related falls in Europe. And they went about this by engaging with 24 experts from 13 different countries and attempted to harmonise the thinking there. So they achieved it very, very well. They have a validated, structured screening and assessment tool, as is recommended in the World Fall Guidelines. And in fact, the World Fall Guidelines refers to stop fall in that. And the nature of it works very, very closely with stop start as well too. So there's no contradiction between the two. So what did they do? They did 3 rounds of consensus, and what they were aimed to do was to get agreement across all those experts on the kind of drugs that they felt were the highest at a risk of falls, the highest falls risk associated with them. They, as I say, 3 rounds of consensus. They looked at 13. They looked at several different drugs. They reached consensus on these 13. So that's benzodiazepines and benzodiazepine-related drugs, antipsychotics, opioids, antidepressants, antiepileptics, diuretics, alpha blockers, centrally acting antihypertensives, sedative antihistamines, vasodilators used in cardiac diseases, and overactive bladder and incontinence medications. So if you were to look at stop fall, you'll see that it's divided into 4 categories. You have those 30 medication classes on one side, and then the next bit is consider withdrawal if any of the following occur. So these are the things, the side effects of the drugs that would increase that falls risk. They went to their experts, and they also asked about whether or not withdrawal was needed. And it's very difficult, I would imagine, with trying to get consensus with there. So it's very much, do you think you would need to do this in a gradual way? Yes, no, maybe kind of thing. And then they were looking for the kind of the issues that would arise after monitoring that would maybe lead you to replan your thinking on that. So that was stop fall. So we decided that we were going to use stop fall as our basic document because it's a consensus document, it's a European document, there's a lot of research going into it. It was going to be our starting point for our own document. However, we ran into a few issues, and to be fair, I think a lot of these issues would have been acknowledged by the people behind stop fall anyway. And once they finished their work with the initial document, they created a task and finish group that are doing a lot of research on the issue that we're finding ourselves. So they're already publishing documents in the area of deprescribing. Yeah, we came across these, we're dealing with it at the moment. So first of all, we felt that the medication classes that were in stop fall were too broad. For example, the antipsychotics, we're hoping to subdivide that into your kind of first generation, second generation. Likewise, the antidepressants, rather than a general kind of catch-all of antidepressants, we would have our SSRIs separated out in our TCAs. That's the way we're looking at doing it. We did feel that the risk of side effects in the symptoms for withdrawal ranges significantly within some medication classes. Now, to be fair, that is addressed in stop fall in their table 1 of that document to some extent, but it was still a concern for us going forward with this one. There really isn't any guidance on steps for withdrawal, and that's something we really wanted to make a very robust kind of a document. It may be that we really need to go back to stop fall when all is said and done, but we are going to try and look at deprescribing guidance that has been produced in the meantime. And I know that Maudsley, for example, in the UK, have produced a document in the last 4 weeks on withdrawal of antipsychotics and dead drugs. There's a lot of activity internationally in Canada and Australia looking at deprescribing, up to date as well, have guidance on it. So if we can really make that useful, then we will do it, but only if it's supported by something that is documented and approved. And I would say we were hoping to work very closely with stop fall and to stay very aligned to stop fall in all of this. We had concerns regarding the appropriateness of providing guidance for certain medications that could be considered specialist, for example, medications for resistant depression. And we had also concerns regarding the appropriateness of providing guidance for the management of certain conditions, for example, epilepsy. So these are issues that we're working through at the moment. Where we are, we're working through the symptoms and we're moving through the guidance for withdrawal. That's where we are. So I suppose we're a lot slower doing it than we thought. It's quite a painstaking kind of an exercise to be doing. We had hoped to be the right side of it. At the moment we're not, but I think we're hoping definitely that the dissemination and the education component, which is significant, I think that's where a lot of the work is going to be. We're looking towards the latter half of next year for it, but it will be very comprehensive. That's our plan for it, and we'll cover all between the acute, primary care, community care and residential care. As regards to accessibility, we haven't spent a lot of time thinking about that yet. That's something that we would need national support for, to decide where best to position our guidance, really. But that's something that will be part of it. So yes, thank you very much for listening. I just a quick thank you, if that's okay, to our managers, Brian Ratigan and Maura Heffernan for on behalf of the nurses here. Also, of course, to Gráinne McCann and Frank Morrison. Very big thank you to Colin and to Deirdre for superb support, absolutely wonderful support. Nothing is ever a difficulty for them. And finally to Jerry, thank you very much, Jerry, for recognising the importance of medication and for giving us a chance with this. We appreciate it. Thank you.